Hello, I'm Dr. Paul Karpecki. I'm Director of Cornea and External Disease at the Kentucky Eye Institute in Lexington, Kentucky. I'm also an Associate Professor at the Kentucky College of Optometry at the University of Pikeville. So I'm thrilled to be able to introduce the Eye Lipid Mobilizer, or ELM. This is a unique product that has, in our early research testing to date, has really fascinated us and impressed us. As you can see a little bit by it, this of course is a little shield that's on the front, but the contours of how it forms is that it molds to the patient. And the big advantage of that is that it does allow us to have kind of this experience for the patient that's unique to them. But it's the intricacies of the design and the way that it works that really sets it apart. It's a very efficient technology, very affordable technology, and very convenient for the patients. What I love about the technology specifically on the ELM is that there's nothing else that has this vibrational stimuli built into it. And when you hear that, you often think, okay, neurostimulation. Actually not. While there might be that component to it, and further research would confirm it, the key here is that you're creating a shear stress to the meibum. And as you know, with patients with meibomian gland dysfunction and evaporative dry eye, that's the most important thing you can target is the meibum. And just heat, which is part of this, and massage, which is part of this, in of themselves are impressive and contribute to the success. I really believe it's that vibrational stimuli that creates the shear force that liquidizes, or liquefies, I should say, the meibum. Because when I use this on patients in our clinical research experience, it's the only time I've ever had patients say they could feel the oils coming out. Sometimes even see the glistening of it there. And the big differentiator, I believe, even though all those components are present in the ELM, is that vibrational component that liquefies the meibum. So yes, dry eye right now is a big topic. People are talking about it a lot. And while it is one of the most common conditions that an eye doctor will face, it's the digital device world that is creating so much notoriety or awareness of it. What I mean by that is when we're on a digital device, we blink about 70% less than when we're in conversation. That lack of blink results in the inability to pull the oils up from the lower eyelid. It's also the blink that pushes the oils, creates the pressure that pushes the oils out. And without that happening, and only happening maybe 70% less, you're not getting those effects. Plus, with the eye open more often, you're getting an evaporation or a drying component. So I believe that's why we're hearing so much about dry eye, is because with digital device use, we're exacerbating the condition. And at the beginning, we get what's called meibomian gland dysfunction. The glands don't work quite as well, but they're sufficient enough to prevent a chronic dry eye. But with time, that goes away, and eventually you do get an immune-mediated disease where the oil glands are not present enough to allow for that evaporation prevention or protection. And so the tears disappear. And that's when we get to the chronic dry eye state. So while there are many causes, and it is considered multifactorial, anything from certain age, gender, menopause, environments like arid environments or places we can work at, wind, airflow. The big trigger lately is digital device use because that's so much a part of our world. We see a significant increased trend of dry eye that I expect to continue for the unforeseeable future, simply because we're seeing it at an earlier age. We are seeing people in their 20s coming in with significant meibomian gland dysfunction or atrophy, meaning loss of glands. When I started working in this field, getting close to 3 decades now, we had a very typical dry eye patient come in. More often women than men because of the perimenopausal components or hormonal components to it. And they were typically 50s, 60s. We always thought of it as an elderly person's condition. That's not the case today. We're seeing the same sort of effects that we would see in patients 30 years ago at an older age, now in their teens, in their 20s. Gamers, for example, have a lot more atrophy of their glands when we examine them. So if they're starting to show effects 3 decades earlier, we can only anticipate we're going to see a lot of this condition in the next decade, 20, 30 years. Digital devices are not going away. You can't suddenly change your ability to blink when you're on one. And so we would expect an increased trend of dry eye disease, especially the evaporative, the oil gland related form of dry eye disease. So when I'm talking to my patients about the ELM, I kind of describe it on what it does. I tell patients that this is an in-office treatment, but has the ability to be taken home because it's contoured to your eyes. So it allows it to work for you and you can use it again at home. And I tell them the unique properties. What I mean by that is, while it does apply massage and it does apply heat, which helps to kind of soften or melt the oils, what really sets this apart is there's a little vibrational stimuli. And I tell the patient, you'll feel it. It's a little mild vibration. What that's doing is creating a little bit of a shear force that seems to penetrate to the meibomian glands to liquefy them. So as this motion is taking place during the 15 minutes they have it on, we're getting those oils out. And I tell them what I've been really fascinated and impressed by is the fact that patients will tell me they feel that immediately after the procedure, or even during the 15 minutes it is on the eye. And that's not something we've traditionally seen with any other technology. I really like the meet them where the need is comment, because if you think about how patients work, some days we don't get as much sleep, which is a trigger for further dry eye or meibomian gland dysfunction. Some days we're on digital devices longer, we're working later. You can't suddenly treat the same way every day. So you put a drop in the eye and you prescribe a medication and you say, okay, use this 2 times a day or 4 times a day. There are times when we have different environments. We could be on an airplane for 8 hours, which is a trigger for dry eye. So the ability to use this as you need to use it, to treat them where they're at, is a big advantage. But I also like the fact that it's something we can do in the office, because that sets it apart. It helps the patient understand how it works and what we're doing. It gives them the effects that they need. It's a very effective device. Patients notice right away how well it's working. That gives them the confidence to then be able to use it at home. And then using it at home gives them the ability to use it when they need it. And that's a great combination, because I had patients when we were testing this, where we just did it in the office. I can't tell you how many times patients said, can I take it home? I'm like, actually, when this becomes available, you will be taking this home. And that gives them the opportunity to not only have it in the office, but then to use it as they need to at home on a regular basis to get the effects they need and the longevity that goes with it. The general benefit to patients by being able to use it at home, besides the treatment in the office, is they can now use it when they need to use it. I do recommend, though, that they use it at least a day or every other day for a period of time. That kind of gets things in the motion it needs. When we did it in the office, patients said it felt wonderful, and they had a few days of effect even beyond that, some much longer, some less, depending on the severity of the condition. But it was so frequent for them to say, I wish I could do this more often. And that's what bringing it home and using it there allows them to do. So it gives me the chance to get the effects early, but then it allows me the chance for the patient to use it as they need it once things are at a good level. And that's a really nice combination. So if they're just flew back on a long flight, their eyes are more dry, or they're on digital devices extensively that day, they have the opportunity to then use it during the day, that evening, whatever allows them to get the effects. And because the mechanism is so different than drops or anti-inflammatories or things we traditionally use, we're getting at the source, the cause. The oil glands that are not functioning well, it seems to have a good effect. And it also allows you to use those other things, but it's directly at the cause as opposed to the downstream results. And I think that's the big advantage. Staff have taken to it extremely well. In fact, I have one staff member who sneaks in to use it herself because the effects have been, and she has access to anything that we have here, of course. Also, the response from the patients has really emotionally charged them, because they hear every patient saying, I can't believe the effects I'm getting right away. While we have a lot of technologies, we don't have a lot that you get an immediate response like that to. And I think they've felt that, the staff. They've noticed it in patients. They've heard the comments, the positive responses, that they've recognized this is something we have to recommend more often. In our clinic, we've had a lot of success because of the combination of in-office procedures and then maintenance. That's really been the key. No one wants to come back and have a procedure again in a month or 6 times a year or something so frequent. We just don't have the time in our schedule. So the way that we've kind of targeted or attacked that for patients is we say, okay, we'll do the in-office procedure, but then we'll try things at home and other ways of maintaining the longevity. What the ELM delivers is both in one. That's very different. That is, we have the ability to do the procedure in the office for patients to understand just how effective that is, but then they have the convenience of being able to then take it home, use it as they have to. So we're targeting not only at the cause or the root. 86% of dry eye has meibomian gland dysfunction. So we're getting near 9 out of 10 patients, this is the cause of their dry eye. We finally are now targeting it, but rather than just in the office, we're allowing them to get that same success from the same device at home. Up till now, we've been doing one thing in the office and very different things at home. And many patients have said, well, I wish I could do what I had in the office more often, but that wouldn't be convenient. With the ELM, it is convenient, and it is affordable, and it's effective. So you have all three built in immediately for the patient to kind of change the way they do things. And I think they like that because they had the experience, and now they're able to do the exact same thing at home and can expect those same results. I would tell colleagues that this is a very straightforward, effective technology to integrate into your practice. And I mean that in a number of ways. Number one, for example, we do a fair amount of IPL and other procedures in our office. When patients come in and they pay out of pocket for that, what they're, I believe, expecting to feel after those procedures is what they get from the ELM. The oils are coming out, the eye feels extremely moist, they can tell the difference immediately. You don't necessarily get that from IPL. IPL has a nice longevity of effect, takes multiple treatments to get to that point, but they want that, what they feel and experience with the ELM. So my thought is, well, let's do the IPL, let's add in the ELM. If it's a practice that didn't have an IPL or other technologies available to them, I would just do the ELM. You're gonna get very good success with that. You're gonna get the heating, the vibrational stimuli, the motion of it, and the massage that allows it to come out. And then you have the ability to then take it home. So really you've got three options here. You've got standalone option for those who don't have it. You have adjunctive to therapies you're already doing or drops that you're utilizing. And then you have the at-home experience. The great thing about the ELM is that the ideal candidate is a very large patient population. I really put it at any patient who has evaporative dry eye or meibomian gland dysfunction that's causing symptoms, which because of digital devices, because of the world we live in, that's a very large population. But it's the patient who wants convenience, the one who doesn't want to have to put things in their eyes on a regular basis or apply things or have to go and you know, if they're traveling, it's harder to get microwaves for good technologies and things like that. So I like the convenience that takes place with this, where they can do it at the office and then also take it home. That ability to use it when they need to really works in any patient who has an evaporative component to their dry eye. And as we mentioned, that's almost 9 out of 10 patients. So anyone where the oil expression is not ideal, anyone with a lot of digital device use, inadequate blink, whether it's because of the actual disease itself, there's people who actually have that incomplete blink, or it's because of digital device use. But those are the candidates that do extremely well. And it's easy to explain it to them because when we press on their oils, it comes out like toothpaste or it doesn't produce or there's very little effect. And so explaining how the heat, the massage, and that vibrational stimuli liquefies those oils makes sense to them. So now it can flow like it should, which is like an olive oil consistency. So any patient with MGD, evaporative dry eye, poor expression are ideal candidates for this. According to research, there's about 38 million people, based on longitudinal studies, that have true dry eye disease, most of it being evaporative from meibomian glands that don't function well. But only 18 million are diagnosed per year, meaning we're missing 20 million people. And I would say that's a conservative number. If you take into account those who have meibomian gland dysfunction, early evaporative dry eye, thinking of all the people on extensive digital device use and gamers and other like that, I'd say that number probably is double, or it will become that with time. So while we're missing 20 million out of the 38 million every year, probably people who aren't aware of it or aren't coming in or missing the diagnosis because it can have different forms and symptoms that come into presence. I believe that it is a greater percentage than that are either early to that, don't know there are options, or not seeing their eye doctor, where the numbers would be significantly greater. Now, that's a huge population already. What's most fascinating though is that we're only treating about 1.5 million of these patients with anything therapeutically. So while we're missing more than 50% based on longitudinal studies, we're not treating about 90%, and that's where these technologies will make a difference.